Welcome to the integrative perspective approach. This is a really interesting topic, so let's go ahead and get started. So, in terms of integrative therapy, now we've kind of come full circle, and I've noticed in some of the discussion posts that you guys are talking about integrating this approach with that approach, or feminist would go really well with person centered, or person centered would go really well with CBT, etc. And so that's what integrative is it's combining more than one approach to say, okay, this approach and this approach might work best for this client specifically. And again, we want to make sure that when we're working with clients, that we're focusing in on what does this specific individual need, as opposed to taking more of just a cutter approach of I'm going to do CBT with everybody and just, cookie cutter CBT, cookie cutter CBT. That's not going to work because we're each so individual and so different, and there's diversity factors to consider, which we've talked about a little bit this class or this semester. And so really figuring out who is this individual or individuals, if you're working with a couple or with a family, who are these people, who are your clients, and figuring out, all right, what's going to be the best approach for them, with them. And of course, taking a collaborative approach. We've talked about that quite a bit this semester, because your clients will also tell you if you just ask them. So typically, when I'm first working with a client, when I'm first starting out, I'll discuss a couple different approaches. This is CBT. This is what CBT is. We could use this approach. Here's EMDR. This is what EMDR is. We could use this approach. Here's ACT. This is what ACT covers. And so letting the client identify what they think will be the most effective with them. Of course, with the, caveat or approach that you can always be flexible and change things up later on if something isn't working. And of course, that's what we would want to do is if something's not working, okay, let's try something else. So I don't know if you guys remember all the way back to the beginning of the semester when I talked about therapeutic relationship and therapeutic characteristics. Of course, those are going to continue to be front and center in our minds in terms of who we are as therapists and paying attention to those things. Because being curious, being a lifelong learner, being able to be vulnerable and authentic when we are therapists, even if it's, of course it's not our therapy sessions, but clients can tell if we show up as, if we show up as fake, or if we show up trying to present a certain way, you can always tell, like, what's going on with my therapist. They're acting weird, or they're being weird. People very much can tell when you're genuine or if you're not being genuine. And so making sure that we're able to be our best selves as therapists in terms of being vulnerable, being authentic, being genuine is going to continue to be important in your role as the therapist. We, of course, want to be service oriented and prioritize what do our clients need, what is important to them. When we make mistakes, acknowledging that, being willing to admit that. And I've had to do that with clients, like, hey, I screwed up here, or I messed this up, how can I make this better, or how can I make this right? In terms of, and why all of that matters so much is if you look at the slide, we're looking at a breakdown of what are the things that end up impacting therapy. And you can see there that one of the biggest factors for this pie chart is relationship. So that's our relationship with the client. 40% is extra therapeutic factors. So that's all the things that you can't control in therapy. That's this person's environment, who they're living with, where they're working, where they're going to school, what their external relationships look like with family or friends, etc. All of that is outside of your control. And so what is within our control as therapists is who we are and showing up to the space, to the therapeutic space in a way that is, again, supportive of the client, empathic, genuine, etc. The other things there are in terms of expectancy, so that's the client showing up with having hope as a present factor. So hoping that they're going to get better, hoping that therapy is going to be beneficial to them. And then you can see there that 15% for this graph at least, and this is from research done by Tasca et al. In 2015. So 15% is attributable to our therapeutic approach, the techniques that we use. So if we break that down, or if we really think about it, who we are plays the biggest role in terms of what we can do to benefit our clients and help our clients get better. Of course, practitioners have been battling over the best way to bring about change and prove that, this is the best therapeutic approach. So there's thousands of research articles out there comparing CBT to any other therapeutic approach, comparing psychodynamic to any other approach. And when it comes down to it, you can see that, yes, maybe CBT is slightly more effective than psychodynamic, or maybe CBT is slightly less effective than, a different research, a different therapeutic approach. But when it comes down to it, the biggest thing again is going to be that therapeutic relationship. So how do we as therapists develop ourselves, because we're part of the tool that helps, we are a tool, right, in terms of helping a client get better, in addition to any other tool that we've talked about, or technique or approach. Everything is, kind of think about it as a tool belt. What, if you're working with a client, what's the tool that you can pull out of that toolbox with a client, with a specific situation, with a specific life event that they're talking about, and say, okay, this tool is probably going to be helpful for this client. Let me try this out. So one of the cool things about integrative specifically is that it enables a lot of flexibility, right? So you don't have to just stick to one approach, CBT or psychodynamic or whatever it is. You have that flexibility to be inclusive across different therapeutic models and say, again, what is going to be most beneficial or helpful for this client. So the ultimate goal of integration is to enhance the efficacy and applicability of psychotherapy. And there's this growing agreement among psychotherapists and based on research that there's no single one therapeutic approach that's most effective or that is the best for all patients or all problems or all contexts. And this is something that I realized very early on in my career. I was working with a client in a substance abuse setting, and I kept trying to do CBT. And eventually I realized, like, he's not getting better. CBT is not helpful. So I have to go back to that toolbox and say, okay, what other approach is maybe going to be more helpful or beneficial with this client, or what technique is going to be more helpful or beneficial, as opposed to, continuing to try to use CBT when it's clearly not being effective. I don't have it here on the slide, but your textbook talks about this eclectic approach. And it's sometimes viewed as kind of a haphazard, almost random picking of techniques without any overall rationale, like theoretical rationale or approach. So we definitely don't want to be random or haphazard when treating our clients. Think about someone that you love, a family member, a friend. If that person were to go to therapy, would you want him or her to get the best care possible, or would you want them to get mediocre care? You'd probably want them to get the best care possible. If your client, if the client is your mom, your sister, your dad, your brother, whoever, someone that you love, our family members, I think my family members, if they were to go to therapy, I think that they would deserve the best care possible. And so I would hope that whoever their therapist is someone who is putting forth effort, is making sure that they're not just randomly using this eclectic, like, I don't know, let's try this today. Like, no, I would hope that that person, whoever their therapist is someone who is intentional and thinking through whatever therapeutic approach or technique that they're using or applying with a family member. And so that's why, again, it comes back to being so important to who we are, that we're making sure to provide the best care possible and taking an ethical approach with our clients. In terms of integrative in general, according to Tasca, which was cited on the previous slide, Tasca and colleagues, in a recent large survey of over 1,000 psychotherapists, only 15% indicated they used only one theoretical orientation in their practice. So the median number of theoretical orientations used in practice was 4. And so, for example, I tend to be pretty primarily CBT, but I'll also pull from other approaches such as ACT, such as the postmodern approaches that we've talked about, narrative, etc. I tend to integrate individual strengths more, positive psychology, et cetera, et cetera. And so there's a lot that you can bring together in terms of taking that integrative approach. Page 429, I believe, of your textbook, depending on which edition you have, cites a much higher percentage. So that cites that 95% of practitioners use an integrative approach. So the vast majority of therapists use some type of integrative approach, not just, oh, I'm purely psychodynamic, or I'm purely CBT, or I'm purely family systems. No, it makes much more sense to pull from different theories and approaches for most individuals, at least, to say what's going to be, again, most helpful for my client. So there's a couple different ways that you can approach integrative. There's theoretical or integration, which is transcending diverse models by creating a single but different approach. So using different techniques, kind of think of this as like trail mix, like what's the different techniques that are all going to kind of mix together to be helpful. There's technical, which is using effective ingredients from different approaches. So it considers the underlying theory, not just the techniques. So what's that underlying theory? Such as acceptance and commitment therapy and dialectical and behavioral therapy. The underlying theories are, pretty similar. There's a lot of overlap there. So think of this as maybe, to continue with food analogies, apple pie and vanilla ice cream. They match, they go together. They taste good together. So then we've got assimilative approach or assimilative integration. So this is working primarily from within one model, but integrating aspects of others when needed. So if I were more purely CBT, I might use, primarily CBT and then kind of cherry pick, okay, I'm going to use mindfulness from ACT, for example, or I'm going to, cherry pick this approach and cover maybe some couples factors if I'm working with someone who is struggling with relationships from like more of a family systems type of approach, for example, as opposed to being more kind of just overall integrative, but more I'm going to stick to that one orientation and maybe kind of just pick and choose. And then common factors approach. So this is focusing on effective therapeutic practices that are common to all approaches. So for example, taking an empathetic, client-centered approach, active listening is common across pretty much all theories and therapies that we've talked about. And even if those theories, think psychodynamic, think Adlerian, think some of those very early on therapies, even if those, historically didn't come across as, who did we talk about? Gestalt, I think, is kind of very confrontational. Or maybe it was Pearls. I'm mixing them up right now. One of the approaches that we talked about, more confrontational. Even if historically those approaches, that's how it was, in today's presentation, how they show up is across the board. Therapist, no matter what your orientation, empathic, client-centered, active listening, etc., is pretty common across all of them. This might be hard to see on the slide, and if so, you can pull up the citation that's there. Essentially, what I want to highlight here is that it, again, across therapies, and you'll see this again on the next slide. Across therapies, we might call things different stuff. We might call it, something for this approach and something else for this approach. It might have different names, but in general, the therapy is going to have some of those main factors, for example, that I just talked about, being empathic, active listening, etc. And so when we take a step back and look at things, there's a whole lot of overlap across all of the different theories and approaches. There's kind of this baseline of what's present for each approach, as opposed to getting into the weeds. So each class we've kind of gotten way detailed in terms of, well, this is what this approach looks like. This is what this technique or approach looks like. But if you take a step back, there's kind of a broad overlap across all of the approaches. Which this might be hard to see in the video, in which case, if you're interested in learning more, you can pull up the citation there, Bass et al., 2014. The article is called A Comparison Between Dialectical Behavioral Therapy, Mode Deactivation Therapy, Cognitive Behavioral Therapy, and Acceptance and Commitment Therapy in the Treatment of Adolescents. And so, again, what I like is that it really highlights what are the similarities across all of the approaches, and then gets at, okay, well, what are the kind of nuances or differences? But in general, what we find is that there's way more overlap and similarity across approaches. I really like that feedback informed treatment is discussed in your textbook because I think it's hugely important. It's become so much more popular in recent years. So essentially, this asks, how do we as therapists know when we're being effective? How do we know that our relationship with our client is being helpful and is positively contributing to this client getting better? And so, feedback informed treatment is taking a more consistent approach with receiving feedback from clients. I've uploaded a file for this assessment within Canvas, but if you type it into, your search engine of choice, of course, it'll pop up as well. If you look up like outcome rating scale or session rating scale. And the nice thing is that there's several different versions. So there's a child and adolescent version, there's a group therapy version, and Miller and colleagues have done a lot of research into using the ORS and the SRS. And so what you do is there's a little blurb that you walk through when you're administering these. And so essentially, in a very like just broad brush strokes, you would administer the ORS at the beginning of session and say something to the effect of, I'm working on becoming a more effective therapist. I want to make sure that, if there are things that are going well or things that are not going well, that I'm making sure to check in on those things and that we're working to improve those things, et cetera, et cetera. And so then the client would, fill out the screener on the left if you're looking at the slide, and they would rate how things are in their life, just kind of overall in general. And then at the end of session, you would give them the second piece of paper, so the picture on the right-hand side, and that specifically focuses on how they're rating their relationship therapeutically. So it might be hard to see on the slide, but if you go find a version online, it says like stuff like, I feel that the therapist listened to me. I feel heard. I feel that the approach or method that we're using in therapy is helpful. And then overall, here's how I would rate this therapy session. And so it's trying to more effectively kind of systematically get feedback from the client to say, all right, are things going the direction they need to be going? Or are there things that we need to be tweaking or changing or improving? And I started using this in my own therapeutic practice maybe a couple years ago now. And I found it really helpful because a lot of times clients aren't necessarily going to be comfortable. If you just say something like, hey, I just want to check in, how's therapy going? Is there anything that I could be doing better? Well, that puts the client in a kind of very awkward, uncomfortable situation where they either have to say, well, this is crappy therapy, you suck at this, which how many clients are going to do that? Not very many, more than likely. Or it puts them in a position of like, everything's fine, everything's great, I like you, you're a great therapist. And so again, how likely is that to, when you're putting a client in that kind of position, how likely are they to be honest and say, actually, I have these issues with therapy? Whereas if you use a paper-based form, it kind of makes the paper the issue as opposed to you, the therapist. And so clients might feel more comfortable with raising concerns of like, well, you said this and it kind of rubbed me the wrong way, or I don't know that this approach is really helping me. What are the other options? And so the paper, because it's like, oh, I'm just putting this down on paper. And then, of course, you would have a follow-up conversation with the client of, oh, I noticed that you put that the approach, you kind of rated it really low. What are some things that we could tweak to improve the approach? What could be different or what could be better? So it really helps with opening up the door to have that conversation with the client, as opposed to, more than often clients are just like, oh, everything's fine. Everything's, there's no issues, when really there might be maybe significant issues. They're just not comfortable bringing that up or saying that. In line with that approach is also this idea of applying deliberate practice to therapy. So when we practice, we rehearse a behavior or an action repeatedly in order to master it. And this has, again, become much more popular in recent years. So deliberate practice has been around for a long time, but it's only recently been applied to therapy and counseling specifically. A lot of research has been done on musicians, on high-performing athletes, what sets these people apart, how are they able to perform at such impressive feats, think of individuals like Simone Biles or other individuals who perform at a very high level, very competitive, very, like musicians, violinists, pianists, etc. Artists who are doing amazing things. And so essentially a couple like therapists came along, psychologists, and said, it's interesting. These people are performing at such a high level. How do we start to apply that to us? Like, how do we start to perform as therapists at a high level and become very good at what we do? How do we apply this to our field? How do we get better at being therapists, at being more effective at helping our clients? I think this is fascinating. This is so interesting. So there's several different books that I have on the slide. I don't own the middle one, although I'll probably buy that soon. I do own the one on the left, The Deliberate Practice for Psychotherapists, and I've gotten a couple chapters into that. If you're interested in learning more, you could type this into your search engine for choice. Dr. Tony Rosmanier. He's written several books, of course, as you can see there. He's got a whole website around this. So if you're interested in learning more, I would strongly suggest either going to his website or typing this into YouTube. There's several different videos there as well to learn if you're, and I don't think it matters if you're being a therapist or if you're going to go on and do something that's not psychology related at all. But my guess is no matter who you are not planning on going into your future career. If you're a student who's not already in a career field, you probably don't want to be mediocre. I don't think any of us go to work and say, you know what, I'm just going to be average today. That's my goal. Most of us want to be above average. Most of us want to be high performers and really knock it out of the park in terms of what we're doing for our work or whatever we're doing in our lives. And so for whatever it is, how do you look at deliberate practice and say, okay, how do I apply this to become really effective in my role or my career, whatever that ends up being for you? So why feedback-informed treatment and deliberate practice? I think I've kind of made a case for this already. We've talked about, I think in previous classes, maybe it was CBT. I've got a picture here, a little meme about being good or bad. And, again, I think we've talked about, I don't like the terminology good or bad because I don't think that that's helpful. But however, there's definitely ineffective or unhelpful therapists out there, which is why I think it's really important for us to start to incorporate feedback-informed treatment, deliberate practice into our therapy approach and into our overall practice so that we're not being mediocre therapists or we're not being ineffective therapists, so that we can make sure that we become very effective, very good at what we do, high performers, in order to help our clients get the best and the most out of therapy so that they can go on and live their lives and become more fulfilled and be happier individuals, etc., etc. So if you're interested in learning more about feedback-informed therapy, this book is really interesting. I've read it. It's really helpful. So I wanted to wrap things up in terms of Stan and Gwen. You guys have worked with them quite a bit in terms of the blogs this semester. So I want to highlight that therapy is more than thinking and feeling. It's also about doing, right? We've talked about SMART goals and setting SMART goals, etc. And so using homework assignments, using exercises or role plays or practice, etc. It's not just about let me come talk and vent for an hour and then, do nothing. But it's how do you help the client accomplish whatever they're trying to accomplish, not only overall, but between this section and next session. What is the client actually going to do? What are they going to go accomplish between now and next session? How are they going to work on themselves? Either through homework that you're giving them, homework that they're giving themselves. Sometimes this can be really helpful where I won't give the client homework, but I'll say, what homework would you give yourself? Because they know where they're at. And so they might say, oh, well, I need to be doing this, and this is what I'm going to work on between now and next week. Perfect. That's awesome. All right, let's check in with that next week and see how that's going. And so again, how do we make sure that we're helping our clients make the changes that they want to be making and not just, coming in each week and then there's no real change happening, or they're essentially just kind of staying in the same rut that they've been in, if you will. And then lastly, even at the beginning of therapy, we want to be thinking about the end of therapy. We want to be thinking about starting with termination in mind, because this person's not going to come see you for forever. They're at some point probably either going to move on, either they're going to move, or you're going to maybe move, or they're going to get to a point where they no longer feel that they need therapy, or they've worked on things enough to feel like, hey, I think I'm good to move on. And so it's always helpful to keep that end goal in mind, to remind both you and the client of where you're trying to get to. What is the client trying to achieve? How do we continue to move towards that? And making sure that we're setting the client up for continued success after their time with us. Again, of course, we want to make sure that we're meeting the client where they're at. We've talked, I think, pretty much at a good amount about that over the course of the semester. Keep in mind, just lastly, in terms of Stan and Gwen's case, that it's a textbook example, right? So everything at this point is kind of wrapped up very nicely for their cases, but it might not necessarily go that way with some of your clients. Some of your clients might come to you for some things or something very specifically. And there might be other things that they could continue to work on, but maybe they choose to do so outside of therapy, or they don't necessarily feel like they want to work on that thing specifically. For example, I've had clients who come to therapy and they have a childhood trauma, for example, but they're like, I don't want to work on that. I don't want to touch that. That's not why I'm coming to therapy right now. I'm coming to therapy to work on this thing specifically. And so even if there are things that you could continue to work on or continue to focus on with a client, there might be things that, based on where they're at in life or what they have going on, etc., that you never end up working on. And so there's this analogy of, we as therapists are, we're kind of like a car mechanic, right? There's all kinds of things. Like, have you ever taken your car to the mechanic and they come back and they're like, you need your 15,000 mile checkup and your 30,000 mile checkup, and you need this and you need that, and you need, this to be done, and your rims could have this done or that done. And you're like, I just want an oil change. Like, that's all I need. I need an oil change and I can keep on going. And they're like, well, you need this thing checked and you need your engine to be, this to happen, etc. And you're like, nope, I just need my oil change. That's all I want right now. We're kind of like that with our therapy clients, depending on, again, who the client is. They might come in and say, I just need this. I just want my oil changed. I just want to work on my communication in this relationship. That's what I'm focusing on. I don't want to work on my depression. I don't want to work on my anxiety. I don't want to work on XYZ, all of these other things. I just want to focus on this. And so sometimes our role is kind of to be that mechanic where we say, okay, that's fine. Let's just get you back onto the road. Let's just change the oil, get you back out there, and we'll be here when or if in the future you feel like you need us, or you feel like you need to come back and work on some of those other things. So I like to keep that analogy in mind as well. In terms of research, so this research was done at Tel Aviv University in Israel. And so we've talked a little bit in a couple other lectures about self-disclosure. So I thought that this would be nice to kind of bring everything together in terms of the integrative approach. So therapist self-disclosure contributes to patient perception of the therapist as warmer, more attractive, particularly when the information divulged resembles the patient's own experience. At the same time, research has shown that disclosing therapists tend to be perceived as less professional. So, disclosures relating to similarities between therapist and patient are found to deepen the patient's self-exploration and exert a normalizing effect, which is important to kind of normalize things for our clients. Frequent disclosures, on the other hand, so doing a lot of self-disclosures, were found to harm the therapeutic relationship, self-displacing the focus onto the therapist and reducing the patient's involvement in treatment. So essentially, we need to be very careful about when and how we self-disclose. It can be beneficial, but too much, or doing it in a wrong way, or doing it in a way that focuses on us and not our therapy clients, can be harmful. So the data gathered, they used a brief symptom inventory, which it's used to measure patients' psychiatric symptoms like depression, anxiety, etc. After final session, patients were completed a 4-item questionnaire evaluating the therapist's professionalism, pleasantness, treatment efficacy, and helpfulness. After termination, therapists were also required to assess his or her own professionalism, pleasantness, and efficacy. Exclusion criteria, so suicidality and psychosis or acute needs for crisis intervention were exclusion criteria, as well as in terms of inclusion criteria, individuals had to be over 20 years of age, and since this was done in Israel, individuals had to speak the Hebrew language. In terms of limitations, so one was the sample size because there weren't very many individuals. And they didn't use the gold standard for identifying psychiatric diagnosis. So, for example, the gold standard would be a structured clinical interview. And because we've talked about this quite a bit, patient self-report measures may not be accurate, right? We tend to have our own biases, so we might present as one way, or we might present as things are either worse than they really are or better than they really are. Future research, so of course there's always room for growth and improvement. You can't do every single thing in one study. So this study didn't look at what's known as positive and negative self-disclosure, so that might be something to look at for future research. And then in terms of immediate self-disclosure, expressing feelings towards the patient, towards the treatment, or towards the therapeutic relationship. So this pertains to the articulation of the therapist's feelings towards the patient, etc. So a therapist might say something like, I've been thinking about the incredible efforts to support your family that you've been doing these last couple of days. It's been hard days for you, and I admire you for that. Or the therapist might say, in the past few sessions, I've experienced you as more reserved and detached than usual, and I'm curious if you're open to sharing what's going on there. As opposed to non-immediate self-disclosure, so this is expressing personal or factual information regarding the therapist's life outside of treatment. So this refers to personal and factual information regarding our lives, such as biographical information, personal insights, coping strategies, etc. So for example, I might say, I also procrastinate, but I've discovered that every time I manage to find a way not to, I'm very proud of myself. Or every time I manage to find a way to, go ahead and take action and do the things I need to do, I feel more confident and more proud of myself. Or another example is, I know from experience that a romantic breakup is enormously painful and really hard to get through. So that's sharing a little bit about myself as an example of, not myself, but the therapist sharing as an example of some of those non-immediate self-disclosures. In terms of results showed that among symptomatic patients, integrative psychotherapy augmented by immediate therapist self-disclosure alleviated psychiatric symptoms more than integrative therapy with either non-immediate self-disclosure or no self-disclosure. Secondly, they found that in integrative psychotherapy augmented by immediate therapist self-disclosure, both patients and therapists perceived the therapist more favorably than those in the non-self-disclosure treatment group. And then finally, therapists, but not patients, in the non-immediate self-disclosure condition evaluated themselves more favorably than their counterparts in the non-self-disclosure condition. And so implications, what does this mean? Why do we care as therapists? Well, therapist self-disclosure, particularly of the immediate type, might enhance the effect of brief integrative treatment on psychiatric symptoms of high symptomatic patients and contribute to favorable perceptions of therapists. So again, kind of what I said at the beginning, self-disclosure can be helpful, but we want to be very careful about when we use it, how often we use it, and we want to be careful about, is it, more directive, non-directive, not directive, more immediate or non-immediate. So paying attention to when we're using it is essentially something to be thinking about. And here's the discussion questions this week. So I want to kind of wrap it up overall, share a little bit about either informed treatment in general, or think about, what you've learned over the course of the semester overall, etc. And these are my references. So you guys have a wonderful week. Please let me know if you have any questions, comments, or concerns. Thank you.